Hi everyone, my name is Scott Tagawa. I'm a medical oncologist from Weill Cornell Medicine, New York Presbyterian Hospital Meyer Cancer Center in New York. And I thank you very much for the invitation to speak at this event. What I'm going to speak about is PSMA-targeted radionuclide therapy, providing the pivotal evidence, and I'm going to discuss a couple of cases. These are my disclosures. I'll leave that up for a minute. It's going to include the use of agents that are currently investigational. So, into introducing the field, there's targeted radionuclide therapy. This is a consensus term based upon a vote in a survey that encompasses all forms of therapeutic radionuclides that are somewhat targeted, so that it can include infusion of beads with Y90 on it. But overall, the field, when we give something systemically, we think of radiopharmaceutical therapy, RPT, and one subset, if we're using a small molecule, such as small molecules against PSMA, that may be termed radioligand therapy, or RLT. What we're going to talk about today is targeting PSMA, which stands for prostate-specific membrane antigen. This is a cell surface protein that is on the surface normally of prostate cancer cells, as well as prostate normal tissue, with some expression on the luminal surface of several normal organs, such as the salivary and lacrimal glands, blood-brain, the small intestine, as well as proximal renal tubules. If you look at the historic literature, it would say that there is 100% expression of PSMA on all prostate cancer tumor cells, but now we know that, of course, is not 100% true. As you can see on the left, figures from immunohistochemistry from our UK colleagues showing both inter and intra-tumoral heterogeneity. One of my former mentees has published on certain organs with prostate cancer metastasis might have, on average, less PSMA expression, such as the liver. And there's a dogma of a relationship, a reciprocal relationship between the AR pathway and PSMA, and then when AR is lost, there is also no PSMA. That is not 100% true, and what is seen in this circle plot is that even tumors that might have no AR or neuroendocrine, you can see it really up to a quarter or a third might have moderate to high expression of PSMA. And we're going to get into the field of theranostics. Imaging is something that is quite important if we're targeting this therapeutically. As I mentioned, targeted radionuclide therapy. This is a not exhaustive slide and not meant to be read in full, but just to show that there are now a lot of investigational agents. There's one approved agent, but a number of investigational agents. Those include small molecules as well as antibody delivery, as well as betas, alphas, and Auger emitters. I think most of you are aware of the VISION study that led to the initial approval in many jurisdictions. This was designed to be for patients with metastatic androgen receptor pathway modulator resistant, formerly called CRPC, prostate cancer, that essentially had all known therapies that were to benefit them. If they were eligible for a PARP inhibitor, they should have got that first. If they're eligible for radium, they should have got that first. But the minimum entry was at least one androgen receptor pathway inhibitor and at least one taxane chemotherapy. They also should be PSMA positive, and we're going to come back to the definition of that by PET scan. They were all given protocol-specified best standard of care, so mostly different hormonal agents, but it could be steroids or external radiation, with or without up to 6 cycles, 4 cycles followed by optional 2 of lutetium PSMA 617, with alternative primary endpoints, meaning either one of them could have been positive and the other one negative, and the FDA would have seen this as a positive study. But as it turns out, both alternative primary endpoints of overall survival as well as radiographic progression-free survival were positive, leading to approval in many places, including Malaysia. Now, not everyone benefits the same, and we look at on a population level, a trial population level, we can look at expression by PSMA PET. And those with higher level expression, whether we look at SUV means or SUV max, those that got lutetium PSMA 617 had an improvement in rPFS as well as OS. No real difference in the controls. Now that's on a population level. Even those that had very low expression, as long as it was enough to get into the trial, still benefited from lutetium over not lutetium. So it's harder to use this in the kind of the real world setting. Now, in the middle, you can see what I would call the VISION, or many people would call the VISION criteria, basically having all known tumors that are active have uptake higher than the average uptake in the liver or the liver SUV mean. and any soft tissue lesion of a certain size, so visceral lesions, 1 centimeter, lymph node lesions at least 2.5 centimeters in short axis, had to have uptake greater than liver. So if there are 10 lesions, 9 were very, very bright, but 1 soft tissue lesion was low in the liver, then that was termed a PSMA negative case. So that's the level 1 evidence, but it's harder to employ in the real world, and some of the times what we get is a written report, not the full pictures. So there's a survey that has gone out, and if you look at the bottom right, this pie chart, the most common that these expert centers used is they see it when they know it. And only the third most common is the vision criteria. So, I think that it is okay in the real world if someone has most lesions covered but not all, and they have a lack of other options. I think that is okay. For instance, radium has worked in the setting of even some lymph node metastasis which can't be targeted, and there's still an overall survival advantage. This is probably a little bit too small for you to read, but just to point out that beyond PSMA imaging, there are a number of other clinical factors associated with outcome, whether we're talking about overall survival, radiographic progression-free survival, or PSA response. Now, clinical trials have certain entry criteria, but that's not necessarily the real world. So this is some guidance from the SNMMI. This really came out after the vision and therapy trials of what would be reasonable in terms of organ function coming in. You can see that the overall vote was a little bit more open than what was allowed in the clinical trials. For instance, a GFR of at least 30, even though it was tighter on the clinical trials, and additional guidance on what to do in the setting of renal failure, pre-existing renal failure, or pre-existing low blood count. So you have that for a reference. Now, to show a case, this is a case of a patient who presented with prostate cancer, was treated, looked to be, have a favorable response, but then didn't come back, and then once he came back, had metastatic disease on CT and bone scan, the PSA that was quite high, was treated with ADT plus abiraterone and prednisone with a good response, but then a couple of years later you can see that the PSA is going up. So this is now ADT and ARPI resistant APMR or CRPC, and happens to have a positive PSMA PET scan, and he says, do I have to do chemotherapy next? Are there any other options? Now, the trials that I'm going to talk about are in a slightly different era where we really didn't have much else. So maybe we're going to try a different ARPI or a change in corticosteroids if the patient really didn't, quote, need chemotherapy right away or didn't want chemotherapy right away. But we didn't have a lot of options at that particular time, so it was relatively common for that to happen in practice and for that to happen in clinical trials as the control arm, because we didn't have clear data that anything else had beat it at the time, at least. So now we have multiple trials, and that's now considered a substandard of care. But we do have 3 clinical trials that have used that with lutetium, radiolabeled PSMA small molecules that are all positive. And I think what you all know about is the PSMA-4 trial. We're going to go over that in greater detail. So PSMA-4 took patients with metastatic prostate cancer, so CT and or bone scan positive, also had a positive PSMA PET, very similar criteria to the vision study. They had progression of disease on ADT and only one ARPI. So this is basically like this patient I demonstrated, ADT and ARPI resistant APMR prostate cancer. They were randomized to alternative ARPI, at least abiraterone and enzalutamide, or up to 6 cycles of lutetium PSMA 617. So this is single agent versus single agent with the primary endpoint of rPFS. And to make this ethical, those that were randomized to the control arm, when they had confirmed radiographic progression, they were allowed to cross over to the lutetium PSMA 617 arm, and we'll come back to that and the implications. But not surprisingly, this was positive for the primary endpoint of radiographic progression-free survival, which you will see on the bottom left. The bottom right shows the final overall survival results, which includes crossover with overall no difference in survival, getting the same drug a little bit later The point estimate of hazard ratio was 0.91, but overall, no difference with the confidence intervals crossing 1. Now, there's a number of different secondary endpoints that were also built in, and essentially everything was in favor of the lutetium PSMA 617 arm. So that included additional efficacy metrics, whether that is PSA, objective response, time to symptomatic skeletal events. AEs, there was actually more high-grade AEs in the ARPI switch arm than the lutetium PSMA 617 arm, and quality of life was also improved with the lutetium PSMA 617 arm. I mentioned the no difference in overall survival. If you look into the final OS publication, first author Karim Fazazi, it'll show that hazard ratio of 0.91, and that in a controlled analysis accounting for crossover, and if you account for crossover, there was an approximate 40% improvement in overall survival. So I don't think of this as a negative trial. I think this is a positive trial. And to be ethical, the patients got it a little bit later, about 7.5 months on average later. So the same drug, kind of that survival washes out. Now, different patient population. This is only a phase 2 trial done in Canada, but a later trial, much more symptomatic disease, and some of them could have PSMA low disease. They had to have PSMA positive disease. This trial allowed up to 5 centimeter lesions to be PSMA low. So it was much more lax in terms of that. Similar patient population in terms of prior treatment exposure, ADT and ARPI. And they were randomized to docetaxel versus lutetium PSMA 617. And there was really no difference. So RPFS, not really difference in terms of the primary endpoints. OS there was an imbalance of crossover. So most of the patients came into this trial not wanting chemotherapy. So almost everyone that got chemotherapy initially crossed over to lutetium PSMA 617. Those that got PSMA 617 first, many did not cross over to receive docetaxel. So I'd say there's probably no difference in terms of overall survival when you account for that crossover. An example of how kind of sick this patient population is, if you look at the PSA waterfall plots, the PSA response rate for docetaxel, we've never seen that in a phase 3. That's very, very low. So that just shows kind of how sick this patient population is. I look at this as this demonstrates, as we've known, docetaxel is a reasonably good drug. Not necessarily that lutetium PSMA 617 is a bad drug. I think there are patients that it's reasonable to give chemotherapy before lutetium PSMA 617, and it's reasonable to the alternative order. Okay, so an additional patient. So what we've shown before is that when someone has metastatic APMR or metastatic CRPC, post ARPI, we don't necessarily require docetaxel for this type of a treatment to work. Would this work earlier? So this is a patient who presents with some pain. On workup is found to have metastatic prostate cancer. This is by CT bone scan. The CT happened to also show a pulmonary embolism. Started treatment. It's a little bit of a weird case because the patient started treatment with an ARPI first, then a week later got ADT. And then that's when I met the patient right after the introduction of ADT and ARPI. And we actually had a different type of a PET scan first. So I knew that the patient had PSMA positive disease, which we'd expect. But the patient was looking for additional options, wanting to be more aggressive on therapy, but not really wanting chemotherapy, asking what could be done. And the patient enrolled in a clinical trial that's called PSMA Addition. So thinking about this setting, metastatic APM, so hormonal therapy naive, meaning no treatment yet, or initial treatment and no progression, meaning sensitive disease. So APMN or APMS is the new terminology. We have the randomized phase 3 we're going to talk about. There's also a randomized phase 2 that was a slightly different era when the standard of care doublet was ADT plus docetaxel. That study, which is I think important to add to the mix because it does demonstrate in an earlier setting this lutetium PSMA 617 can coexist with chemotherapy. That's the primary endpoint of PSA, as well as a number of the secondary endpoints were positive for ADT plus lutetium PSMA 617 followed by docetaxel versus the old standard doublet of ADT and docetaxel. But getting into PSMA Addition, so this was patients with either de novo, meaning walking in the door with untreated metastatic disease, or recurrent, meaning prior treatment to the primary surgery, radiation, or any other treatment, and then have recurrence that is metastatic on CT or bone scan. Also PSMA positive with a much broader definition of PSMA positivity. Just one lesion has to be greater than liver because the control arm gets good treatment overall. They were all treated with ADT plus an ARPI of physician choice, whatever is approved in that jurisdiction, and then randomized to that doublet alone or that doublet plus the addition of lutetium PSMA 617 up to 6 cycles. Primary endpoint of radiographic progression-free survival with also built-in crossover. So at confirmed radiographic progression, those that wanted to could cross over to lutetium PSMA 617. You can see the baseline characteristics here. Basically, overall well-matched, both de novo and metastatic. Not surprising that the majority had charted high-volume disease. That's what we tend to see in these trials. And the bottom line is that the primary endpoint as the study was designed was positive. There was an improvement in radiographic progression or death as the primary endpoint. This improvement was consistent across all the different subgroups. If you look at this forest plot, an updated analysis was presented at ASCO 2026 that not just radiographic progression, but additional other endpoints were also positive across all of the subgroups more or less evenly. So this triplet is a benefit kind of regardless of all the other clinical factors. Initially, we couldn't show the whole thing, but additional data on PSA was presented at AUA in 2026. And one of the kind of landmarks that we look at in this patient population is, do we achieve a PSA that's less than 0.2 within the first 6 to 7 months of therapy? And you can see that we also achieve that with, this is not something we always look at, but a PSA less than 0.02 was also in favor of the early lutetium PSMA 617. The median follow-up at this analysis was about 2 years. So this is very early for this disease patient population. When we look at overall survival, there is no difference. However, intriguingly, the point estimate happened to fall below 1, but this is very early and we need additional follow-up to see if this is going to happen. That is despite crossover. Now, of course, there may be adverse events, and I didn't have time to mention the adverse events in the other section, so this will cover kind of everything. One thing to remember in a combination, there may be adverse events from any of the drugs, ADT, ARPI, and what I'm going to focus on are those that were higher in the lutetium PSMA 617 arm. So some general or constitutional adverse events, such as fatigue, were more in the 3 versus 2 drugs. But many of the adverse events are likely related to areas of normal PSMA expression in the body. So salivary and lacrimal glands, so salivary glands like can lead to dry mouth or change in taste. There can be uptake in the small intestine, so nausea, vomiting, bowel changes. And we know that the beta emitter has a relatively long range, so either circulating through the bone marrow or landing in a PSMA-positive tumor in or near the bone marrow might have a crossfire effect leading to some myelosuppression. Now, despite a higher amount of adverse events that was all grade as well as high grade with this triplet, the addition of lutetium PSMA 617, there was overall no difference in time deterioration of patient-reported outcomes. That being said, you can see maybe there's a little bit of a trend. So we took a deeper dive, and Mike Morris presented this at ASCO GU 2026. So the primary analysis was at any time someone had a deterioration in patient-reported outcomes, they were censored. So even if the patient felt great the next day, they were already censored. That's not real life. If someone has an adverse event or a car accident and doesn't feel good today, what is most important is the long-term effect. And what you can see here is that 2 out of 3 of the patient-reported outcome tools were basically the same, 3 versus 2 drugs. The FACT-P did have a drop-off, and this is very similar to chemotherapy or to PARP inhibitors initially, but then there was catch-up, and after the first 6 months or so, the patient-reported outcomes evened out across the arms. So not a detriment, it looks like, over the long run in terms of quality of life. Now, I'm not going to go through this in great detail. This is most of these are not kind of prime time, but makes sense that we might do some combinations. So chemotherapy combinations make sense. Taxanes may radiosensitize, going to hit PSMA low tumors with chemotherapy, so that makes sense. The mechanism of action of this type of a therapy is radiation, so radiosensitizers would make sense. Looking at hormonal therapy. So hormonal therapy may work on its own, but it also may increase PSMA expression and also radiosensitize. So this, I would say, is the type of therapy that is prime time, at least when we're adding the lutetium PSMA 617 in a phase 3 trial called PSMA Addition, which we just discussed. Maybe the addition of this type of irradiation, so rather than one site of radiation, such as external beam, this is getting most of the radiation, so needing less of an abscopal effect. Interesting early data with combination with immune checkpoint inhibitors. And then there have been a couple of early trials combining targeted radionuclide therapies, either two different targets or the same target, alpha and beta. So this is coming back to the case, presented with metastatic disease, got treated with darolutamide followed by ADT, enrolled in PSMA Addition. He happened to be randomized to the intervention arm, and you can see he had a very nice response, essentially a complete response. So that complete response coupled with his hemoglobin that started off at around 11 and then dropped to less than 10, following that per protocol, we were allowed to hold. So he stopped at 4 cycles and then continued on the ADT and darolutamide, which not surprisingly worked for maintenance. Now, what I've been talking about so far is really just the beta emitters. Alpha emitters are possibly the next wave. So we, in prostate cancer, have the only approved alpha emitter in terms of radium-223 that targets bone. But you can see here there's a number of different investigational targeted alphas against PSMA, and that includes a couple of drugs that are now in phase 3. So we'll see what happens in the future, both looking at the post-lutetium cohorts as well as head-to-head against lutetium, at least a subset. Radiation, we know, can have acute toxicity, and I showed some of that in terms of the PSMA Addition trial. There may be some long-term toxicity. We don't have long-term follow-up. We really have about 2 years of follow-up right now, but we know that there are certain organs that we think may be at risk or are at risk. How much risk that is going to be, we'll see. We're thinking about what's going to happen to the bone marrow, what's going to happen to the kidney function. So I think that we need to be careful about these and keep in mind that some pre-existing factors, such as starting with colon hematopoiesis and cytopenias, that's probably a high risk factor for myelosuppression, or starting off with poor renal function, or comorbidities that may contribute to poor renal function. Now, taking a step back, in the world of solid tumor oncology, we've traditionally had these 3 pillars. We've had the surgeons, we've had the radiation oncologists, we've had the medical oncologists. I think that for all patients in all situations, a multidisciplinary team is important. I would say it's absolutely necessary for this type of a treatment when the kind of primary caregivers, which are typically the medical oncologists or clinical oncologists or the urologists, will see the patients to treat them but are not licensed to administer these radioactive compounds. So I think we need to work together. I think the multidisciplinary teams, when they include additional members of the healthcare team, are probably even better. And then when we include family and social support, even better. And then I'm throwing in, pet therapy. It doesn't have to be a dog, but pet therapy can also help. So I think this is quite important in this particular setting. There's additional guidance. Some of the times, if I'm seeing the patient and refer to nuclear medicine or radiation oncology, some of them can take care of the entire patient. They can continue the ADT, whatever else they're getting, continue the bone health therapy, take care of the adverse events. But a lot of times, they're the ones that have the expertise in terms of the targeted radionuclides, but we need to continue to follow the patient and check them in between for blood counts and chemistries, and decide with them on the next cycles and provide the supportive care. So I think that this is just an example of additionally why, even once we make the decision and start therapy, that we need to work as a multidisciplinary team. So in summary, PSMA-targeted radionuclide therapy has one approved drug, lutetium PSMA 617. It is approved in multiple jurisdictions for metastatic APMR or CRPC disease that is PSMA positive with prior exposure to an ARPI, with or without prior exposure to chemotherapy. It may be moving earlier. There's randomized phase 2s as well as randomized phase 3, moving earlier to the APM-N or S, formerly hormone-sensitive disease setting. It's even trials looking even earlier. And maybe the next wave is going to be additional lutetium agents, but following that, I suspect that we're probably going to have some additional alpha agents as well. And then the last kind of important point is just a reminder that probably all care, but in particular target radionuclide therapy will really benefit or really need a multidisciplinary approach. So thank you very much for your attention.